Yeah, good afternoon all. We are aware that raised intracranial pressure causes papilledema and this causes significant vision loss. So it's important that we have to reduce the ICP. Now in certain cases you need an optic nerve sheath fenestration to relieve the compression on the optic nerves and thereby preserve or improve the nerve function. But what happens if there's an atrophic papilledema, relatively flat nerve head and failed nerves? In this, can we do something? So this was a research question where we want to report our experience with optic nerve sheath fenestration for visual loss in those with atrophic papilledema. It was a retrospective interventional study over the last 10 years and we found 48 eyes of 27 patients which having this disease. They followed the normal protocol and each of this was analyzed for our study. And we included only those cases which had a raised ICP on maximum treatment with the presence of disc pallor with or without disc edema. But the B-scan classically showed the subarachnoid fluid with the hypoechoic crescent confirming that it's a raised ICP. All these patients had undergone optic nerve sheath fenestration by the medial conjunctival route by me. We looked at the outcome measures with terms of the visual acuity, the visual field, improvement in the central field, and disc edema, whether it was persistent or completely resolved. These were the 48 eyes of 27 patients, and what we found out, 21 eyes, that is 44%, had clinically flat discs seen on fundoscopy or on OCT. About 50% of them had raised ICP due to idiopathic intracranial hypertension. As you notice, all of them had enlarged optic nerve sheath, which resolved after surgery, and they had visual fields which were completely constricted, done only in 17 eyes, and we had all about minimum 6 weeks follow-up. So these were the surgeries done. We had two groups, one is unilateral and the other one is bilateral. Of the 6 unilateral eyes, we operated the 6 patients. We had 4 patients having good vision, so we operated the worst eye. Among those with poor vision, 1 patient had relative vision in the left eye, so we operated that child. And 1 with no PL, we operated one of them. Among the bilateral, we had 42 eyes. Of this, 12 patients of 12 eyes of 6 patients had vision from 6/6 to 6/60. In the poor vision, we had 16 eyes of 11 patients with counting fingers close to face and 5 meters, and 14 eyes of 7 patients with either hand movements, PL or no PL. So among our results, all patients with good vision did well, either improved or stabilized, and visual fields did improve. Now, those with poor vision were stabilized in both the groups and even improved, but had some ambulatory vision. But those with no change was noticed in those with significant vision loss. So let's look at one patient who had good vision in one eye and poor vision in the other eye. As you can see, 618 parts, and these were flat discs. If you look carefully, this completely constricted optic nerve, the field showing that it is completely blind. And if you look at the discs on OCT, they are flat. So many a times, this patient has refused surgery elsewhere when he came to me. And if you look at his B-scan, there's significant fluid around it. And we went ahead with surgery. Look at the cotton peanut. It is right at the place of the optic nerve sheath. And if you look carefully, this is so much ballooned. And when we go in the medial conjunctival space and make a nick on the optic nerve sheath, see the amount of fluid. So this patient has significant fluid. This is a decompression technique that we done, which is followed by making a nick inside and removing a part or the window of it. That is a fenestration. So the pre-operative B-scan which showed the SAF after surgery was completely resolved. And this patient is now 18 months later having had improved vision. So many a times they come with flat discs but have a deteriorating vision and therefore need surgery. So coming back to our summary of results, so we had 48 eyes, of which 24 eyes had vision better than 6/60, all did well. We had 10 eyes with vision less than 6/60, of which counting fingers close to face to 5 meters, they had ambulatory vision, but with poor vision cases did not change at all. So in summary, 34 eyes, that is 71%, with a vision of at least counting fingers close to face to begin with, maintained ambulatory vision in all these patients, with 23% having an improvement and 48% having resolution. The complete resolution was noted on B-scan in all of them. The disc flattening starts about the first week and gets completed by 4th week. Fields improved in about 17 cases, either as stability or complete improvement, but there was no vision-related complication. What we already know is that there is ONSF definitely works, and it is about 80%. But what we don't know is that there is no atrophic papilledema ever considered in these cases. So what this study tells us that it is the first study talking about atrophic papilledema, and it's a must in these cases. Early ONSF will help salvage vision even in pale and flat discs. And B-scan is an important tool to find out whether we should intervene or not. Remember, there's no role of ONSF if the vision is either hand movements, PL or no PL. But if there is counting fingers at least close to place, we should do it to get ambulatory vision. We as ophthalmologists must understand that to prevent blindness in these patients, anybody can do this surgery if you do it at the right time to prevent blindness related to a disease which the neurologists and the neurosurgeons handle. Thank you very much.
Very nice presentation, Dr. Jyoti. I have few questions to you.
Yeah.
You have taken all cases of vintage papilledema, those atrophic papilledema. So have you checked the opening pressure? Because we know the chronic papilledema is one of the cause for this.
Yes.
So what was your opening pressure which helped you decide the surgery?
So all these patients had a high opening pressure. Some of them were IIH cases, some were cerebral venous thrombosis. They were managed completely by the neurosurgeons.
No, I mean the CSF opening pressure.
Yeah, CS was more than 300. 30 millimeters, 300 millimeter, 30 centimeters of water.
Okay.
This concept of atrophic papilledema is coined by you, or it's
No,
in
it is a known,
literature?
it's a known entity.
It's a known
Yes.
entity.
So what happens is papilledema have 4 grades, of the 4th being atrophic. So when it's atrophic, the discs appear flat. So people feel it's flat disc, there's no need to operate. Anyway, the discs have resolved. But what happens is behind there, this is the SAF, which is communicating, is still causing the whatever vision left in that optic nerve to further deteriorate, and then they go into no PLPL. So if we catch them at that time, we can at least salvage that ambulatory vision.
Second question, have you started with any oral medications before? And
Yes,
for
we
how
have.
long you have waited?
So they wait for at least 6 months. So it's not only about waiting. We monitor each of them in terms of the vision. We look at the visual fields. If any deterioration is noted, we keep on a longer follow-up. But anything less than 5 degree of constriction of the fields or vision dropping less than 6/18, only then we intervene.
And what was the dose of the acetazolamide that you've given?
If we give as high as 2 grams.
2 grams per
Yes.
day.
Yeah.
Okay. And you have operated on one side or both the sides?
No, that I said, 6 were unilateral. Rest of them, where there are no PL hand movements, I want to give benefit of vision to all of them, so it's bilateral case.
Was the medication continued after the
Yes. So what we have to understand, I have just salvaged the optic nerve, but the treatment has to continue with the neurologist and the neurosurgeon because the problem is in the brain, not in the eye, so that should continue.
Thank you, Dr. Jyoti.
Thank
I
you.
appreciate your confidence.